these areas which are very prominent. I have worked on most of these areas for the better part of about 12 to 15 years now. So I'll show you some of the work which we've done with regards to AI in these different areas. So then, let's talk about the first one, which is diagnosis and imaging. So in my opinion, as we stand right now, I think the most relevant use of AI is in terms of diagnosis as well as predictive analytics using these diagnostic records. So, like we can use AI to examine, collect, organize and catalog data, which are very essential steps in forming a very good quality AI model. So when we talk about artificial intelligence, we need not just the numbers. So you will see a lot of research being put out with lots of AI models coming out. So one aspect of building an AI model is the quantity of data. The second is the quality of data and whether it answers a particular question or not. So with regards to that, we have potential applications such as diagnosis and treatment planning, automated landmark detection, assessment of growth and development, and then treatment health outcomes. So I'll elaborate on these as we go on a little bit with some of the work we've done. So in terms of diagnosis and treatment planning, one of the uses has been in terms of landmark identification, time saving, because I'll show you how much time does it take to do a conventional analysis versus what we would normally do with AI. So in terms of accuracy, this is already about 10 years ago when we had accuracy levels of about 84 to 93%. And we've had major studies where we found that automated landmark detection is almost as accurate, if not more, compared to human expertise. Because the human eye has fatigue, we have technical errors between, if you make 10 orthodontists sit in a room, I'm very sure we all have different landmarks. We might have slight difference in values, which is almost at par with what you get with the current forms of AI. So one of our new projects, I'll show you some of the projects which we have been working on. Our focus is a lot on increasing clinical efficiency. So one of the new projects which we developed was improving extraoral photography. So we developed a model which was known as lightweight. So it's currently in its last phase of beta testing. So I'll show you some of the work which we've done here. So when we talk about extraoral photography, which is very important for all of us as orthodontists, so we have some very common errors that we witness. This could be in regards to either the orthodontist position or even the patient position, where you could be in different positions as an orthodontist taking records. Even the patient could be, let's say the face is slightly to the left, slightly to the right, or facing up or facing down. So what we thought was these were common errors which were compromising how we look at records before and after treatment, or even mid-treatment, because we tend to take a number of records. So we developed a model using different forms of facial angulation. We took almost 780 data points on the face. We triangulated all these positions to form a model which was known as lightweight AI. So this project was developed with Tokyo Dental College in Japan, and we developed this model called lightweight AI, where we use a smartphone camera and we enhance the camera which is already inbuilt in your phones to be able to standardize extraoral images. Now, how this differentiates from, we were very worried about data security, because one of the problems is you download third-party applications. These applications tend to keep your patient data, and this is common with most of the applications you know. So what we thought was it's not appropriate to collect patient records, so we just enhance the camera, but the patient images stay on the doctor's cell phone or the doctor's mobile phone. So I'm sure the face on the screen looks familiar, even though there's a mask in front. So we have these data points. We even standardized the position of the eyes, the eyelids, the lips, and we have these data points. So the next time whenever you record an image, the patient has to be in the exact same position. Otherwise, you won't see these, you see these three arrows for the facial angulation, the head position, and lastly, one position in the transverse plane. So when you look at the patient's head tilting one side, till the time you see all the three ticks go okay, you won't be able to capture the image, which makes sure that your patients are in a comparable, standardized format every time you take an image. So this was one of the projects which we worked on in terms of improving diagnostic records and standardizing them. Another project that we recently completed, which was automated profile and divergence calculation. So we again published this in a very well-known journal, in the Journal of Orthodontic Science. So this is an app which is known as literally it's called as Face Analyzer. So this was an app which we developed. We collected a lot of data, and then just taking a picture, you can find out whether the patient's profile is straight, convex, concave, and whether the patient has a straight divergence, anterior divergence, posterior divergence. So what we thought was, instead of having one big AI-based application, we wanted to develop a number of small AI models which could be combined later to form a bigger AI data set. So keeping this in mind, I also wanted to bring up the point where we talk about whether decision making in AI is correct or not. So this was a very valuable paper which I read a couple of years ago, which was published in the Journal of Korean Medical Sciences. It talks a lot about the decision making process, how it differs between humans as well as AI. So one of the areas where it differs a lot is in terms of, we call this EQ versus IQ. So EQ is the emotional quotient and IQ is the intelligence quotient. So we as orthodontic practitioners, we rely a lot on our experience of dealing with certain kinds of malocclusions, certain kinds of cases, so which influences how we treat the next case that we see. Whereas AI just relies on data, it removes that emotional quotient. So on one side, it will help you form a very neutral, non-emotion based decision. But then you also see the other aspect of this, which is us being orthodontists have to be compassionate and empathetic towards our patients. So we have to take these IQ-based decisions into account and then make an informed decision in the best interest of our patients, which is what AI is currently not capable of. So this is why I always show you the good side, but I always like to highlight the challenges we have with AI as well. So these are some of the findings where we found out that AI is very good at rational decision making, provided it has good quality and good quantity of data. But then whenever data is lacking, we still end up going back to human expertise. So again, I've tried to raise these points. Again, this paper was published in the Journal of Evidence-Based Dentistry, which is a part of the Springer Nature group, and the second was in the German orthodontic journal Kiefer Orthopädie, which is again talking about consistency of orthodontic decisions. So again, what we found out was that there was low consistency in the clinical decision making when it comes to orthodontists. Let's say we have person A or an orthodontist A who went to a particular school. We have another orthodontist who went to another school. How often do you think there's a chance that those people will have matching clinical decisions? So again, our decision making is influenced a lot by who we learn from, which schools we go to, or what kind of biomechanics is taught there. So this is also what affects our decision making as orthodontists. So then, coming back to what we were discussing before in terms of accuracy of these models, so wherever there are numbers involved, of course AI is very accurate. So we had a systematic review which we published before, where we found again AI-based cephalometric analysis is almost 94% accurate, which is comparable very easily with how we would look at these sets. But I think our major benefit is in terms of the time saved, is in terms of the efficiency, because that allows us more chair time with the patients. So again, what we found out was that AI-based automated algorithms work very well, comparable with human accuracy, but again, these do require human decision making. So then I'll give you an example of a patient we treated. So the patient was referred to us. He had already been to a couple of practices. The patient was a severe class 3 patient. So he was recommended to undergo surgery everywhere. So when you look at his facial profile, he has an open bite, full unit class 3 canines, class 3 molars. So by every bit, it looks like a surgical case. So then, in terms of treating a severe class 3 case, there was a very nice paper which was published by one of the stalwarts in the Indian Orthodontic Society, which talks about having functional occlusion in complex cases. So it talks about finishing a case with class 1 canines, probably compromising this in case the patient does not have the option to go for surgery. So when we evaluated the records, so the first thing which comes to mind usually is, when you look at these records, it takes a lot of time and effort to carry out one landmark analysis, draw the planes, measure these. So some of the important landmarks which we utilize are one, probably the IMPA, A and B angle, as well as the extraction index. So to compute the extraction index itself, it takes, you have to calculate the overbite depth indicator, the anterior posterior dysplasia index. So it's time consuming. But when you just use AI, it takes you, once you've confirmed the landmarks, it takes you about 5 seconds till you get these values. Now it's up to us as practicing orthodontists on what would be the best decision to make for the patient. Because there are times where I have seen where the patient has spaces in the arch, but AI fails to detect those on a 2D Ceph. So we have to take these readings with a pinch of salt and be very careful, relying completely on these records or softwares for decision making. So again, in this patient, it was favorable because we just made a treatment plan to intrude the uppers, flatten the occlusal plane. Possibly using the extraction index, we decided on an extraction based plan so that we could treat the patient so that he could get a better profile. So we started with lower arch extractions, high placed transpalatal arch in the upper to get some intrusive effect. And by the time we were finished treating him, so we finished with class 1 canines but a compromised class 3 molar relationship, and we managed to get a very good profile change for this patient. So again, this was pre and post Cephs, the composite image, as well as this was his profile. So again, there is one aspect of using AI to help you decide some of the plans, but then it's a lot of work involved on our end using these plans as well as diagnostic records to good effect. So these are some of the papers which have shown that there is minimum 80% accuracy in a lot of these models. So again, just to highlight a point, for an AI model to be valid for human interventions, there has to be minimum 75% accuracy. Anything below 75% is usually not considered very accurate. So then we've had a lot of studies which have, in some areas where it's data-based, you can see it's very accurate. Some areas where it's part data-based but part it relies on other kinds of data like study models, pictures, there the accuracy tends to become a bit lower. So the main benefit is in terms of the time required as well as the efficiency. We need a lot of paraphernalia if we are carrying out manual tracing. For those of us who've trained, like it takes lots of effort to manually trace these. Again, like there was a time for this, but then these days, because we have the advantage of using these applications, so we have lots of applications. So again, I have no commercial interest with the application, but then this is one of the very prominent applications where you verify the landmarks yourself and it only takes you about 20 to 60 seconds. And most researchers have found out that the accuracy ranges between 88% to 92%, which is very good in a lot of ways where we can also put in some inputs and then we're very sure about the treatment plans. But then let's look at, this was the diagnostic aspect of using AI. Let's talk a little bit about how we can improve treatment planning. So again, I'm sure most of you have seen this movie. This was, I think, probably the first Iron Man movie which came out in 2007. So we got an idea from the way Jarvis was being used. So we thought it's a very good way to think of objects in a 3D spatial plane. So we started working many years ago on this project called the Extended Reality Project, where we were trying to incorporate a lot of AI into how we use these or generate these XR models. So we started with the initial iterations, which were AR, VR. What we've been working over the last few years is extended reality, where we started with the headsets. Now we've done away with the headsets. We can basically use our mobile phones for the same purpose. So some of the projects which we've published is in the British Dental Journal, where we're trying to highlight again the use of extended reality. And I'll show you an example of where it was very valid. So this was a patient who was again referred to our practice because I think she went for treatment somewhere. They started bonding. I think when they took the panel, they found out that she has bilateral impacted canines. So then we needed additional records to be able to make a plan for her. So here you can see the overlying canines on top. But then we again come back to numbers and data. So then if you just go by standard data, if you look at data, it says 91% versus 64% chance, depending on whether the canine is nasally placed or distally placed. But then this only takes into account the position of the crowns. But then there was also another classification talking about the root position, which says, depending again on the position, the canine root apex lies in the green, yellow, or the red zone. So if you look at data, we thought, okay, so since this is the initial position, why don't we try to improve the position before we try to bring a canine out? So initially the records were here, so you can see this canine is possibly on the range between the yellow and the green. This one was almost at the border of the yellow and the red zone. So conventional techniques would require opening flaps or maybe a bunch, but then this is all based on 2D data. So what we thought was, why not try to enhance how we provide treatments? So we developed what we call as XR models. I'll show you one or two iterations of this. So then we developed, these were the scans of the patient. We use the CBCTs. We have an automated process where we can convert the STL files into these AR XR images. Now, if you look at this again, you'll see much more clearly that there is less bone on top of the right sided canine. There's much more on the left side. So this was the whole process as to how we convert the overlays to the XR models. But then once you make these models, these tend to show up here. So I'll show you how these show up. So there's literally a QR code which you can share with your patients if you wanted to. The patient also sees what is the initial severity, complexity, so they're more compliant when they understand it's a bit more severe. So these models can be scanned and opened up anywhere. They could be opened up in front of, next to a coffee mug, in your clinics. So one, it allows for enhanced visibility. Second, what we've tried to do is to use these as base models to 3D print guided exposures. So based on this, we decided to have a plan wherein we remove the third molars. We wanted to improve the angulation of the canines first. So we placed screws in the interarticular region between the premolars and the molars. And we started with, because we already knew, so we just carried out very pinpointed exposures of the canine so that we could try to move it safely and just correct the angulations first. So it took us a couple of months, about 6 months later, we started to see some improvement in the position of the canines, while we just aligned the lower arch. Then a couple of months more, this is roughly about 14 months into treatment, that now we could see the canines on the distal aspect, so we just used piggyback auxiliary wires to try and manage the canines and bring them down. Few more appointments, we could engage the canines directly, but because we were trying to bring the canines down so the bite was opening up, some more months, the canines were down, so now we just had to use a combination of class 3 elastics as well as anterior bite closing elastics. So it took us almost about 27 months of precise planning to get the canines from here to class 1 position with class 1 molars. So this was the initial iterations of where we were using AR, XR models. So this was how the patient finished. And So in terms of that was the first iteration where we thought, okay, we have to 3D print these models and we try and plan exposures. The second iteration was we realized there are a lot of places where these models can help us improve treatment delivery. So now we thought like there are patients where they have less interradicular space and we need more time trying to place screws here. Plus, for a screw to be successful, you have to have sufficient bone around them. So what we thought was one option is to print a lot of 3D models, try to plan this on the 3D models and see which iteration works better. But then when we have access to AR, XR models, we can literally just do all the planning in a virtual reality environment. So now the good thing is we can see the roads exactly. We can plan what is our point of insertion, what is our angulation of insertion, and exactly how deep do you want the screw to be placed. And once you know what is the accurate point of placement, we can use that as a template to print a 3D printed guide, which can be used for exact placement for the mini screw. So now we know these are the two preferred positions. So we just place printed VR guides so that we can do guided mini screw placements. So these are some of the things which we've been working on in terms of treatment delivery. And this is one of our recent case reports which was published where we've again corrected a scissor bite just using a guided TADS insertion and then just a simple retainer for coverage. So again, there's a lot of benefit of using a lot of these appliances, using AI to our advantage. Then our most extensive project was the predictive model which we tried to build. So this took us many years. In fact, if I'm not wrong, it's almost 7 years where we worked on these predictive models. We were the first group to develop 7 AI models and cross-validate and test them. So the whole idea was, you keep seeing a lot of the airway models. My whole problem with all of the airway models is that everyone thinks of the airway as a whole. Whereas we all know for a fact that the airway has different parts to it. And there is linear measurements to be had, there is volumetric measurements to be measured. So we developed this project whereas at Thammasat as well as Kasarsan University in Thailand. And we completed, just last year we completed this 6.5-year project, wherein these were the co-collaborators on the project from both the universities. So we subdivided this project into 2 parts. One was just the landmark identification, data collection, and we wanted to clean up the data to find out whether there is actually an association between certain landmarks that we believe there should be. If not, we'll try and clean up the data, then we try to build up more accurate AI models. So the first part was published, which is the retrospective analysis. So we used a lot of CBCT records. We analyzed these, we isolated the sets, we did some linear measurements, we used the CBCTs for volumetric measurements, and we had the reason why it took us very long was we had a very specific data set we wanted to generate, which is having equal numbers of class 1, 2, and 3, and equal numbers of each male and female genders as well. So this whole data collection process took us very long, and you can see we have some volumetric measurements where we measured these using the CBCTs. We also have some linear measurements for which we took the sets isolated from the CBCTs. And then we subdivided the airway into 4 different landmarks: nasal cavity, nasopharynx, oro, and hypopharynx. Using this, we then cleaned up the data using MATLABs as well as cluster analysis. So I'll show you how the cluster analysis looks as we go ahead. So what we found out was that there was a very distinct association between class 3 patients and the nasopharyngeal volume and class 2 patients and the hypopharyngeal volume, which you could see in the clusters as well. So wherever you have distinct clusters that you can see, this data is usually considered more accurate, versus you have diverse spread for some data and missing clusters, which means this data is not so reliable. So we removed some of these factors from the AI models because we found out they were not very predictive in any sense. So then we came to what we found out was again distinct associations across genders. For females, there was a distinct association between ones and twos in hypopharynx, and again there was a distinct association between one and two for males as well. So then, once we carried out this analysis, it led us to the second part, which was developing the AI models. So we used 5 tests. We developed 7 AI models using this data. Then we started to cross-validate them with 90 samples. We were not satisfied with the CV values we got, so we increased this to 150 samples. Out of this, 150 were trained and then another 150 untrained, which means we did not know how these would reflect. So this was again published in PMC Oral Health some time back, which is the development and validation of these predictive models. So again, we developed these 7 models, which is literally all the 7 commonly used models: decision tree, random forest, gradient boosting, SVM, KNN, logistic regression, and neural network. And what we used to validate was a confusion matrix. So again, in terms of validation of an AI model, this is very essential, because a confusion matrix will tell you certain things, such as the ratio between true and false positives, false negatives, and true negatives. So true positives means it's correctly predicting, false positive means it's incorrectly predicting the presence of a condition when it's not there. We have false negatives, which means there's a condition but it's not being detected. And then we have true negatives, which means it's correctly predicting that a condition is not there. Now again, imagine in the human context how important it is for us to correctly predict or have false negatives, because we can't have reasonable accuracy and tell a patient you have breathing issues, you have sleep apnea or something. So then these were the 7 AI models that we developed, and then we cross-tested them to find almost, finally we ended up with 75% for both genders, 80% for males and 75% for females. Now we're still in the process of trying to improve this. Our whole idea was to develop a very low-cost predictive model where we could just take a CBCT and tell a patient, okay, you might be at risk. It's not our work essentially to try and treat this, but if we can try and tell the patient with reasonable accuracy that you should go in for further testing or see an ENT, I think that should hold us in good stead. Instead of spending $4,000 for a sleep test, it's very economically viable if we spend $70 or $80 for a CBCT. So then we have, this was mostly talking a little bit about what we can use in terms of treatment planning, in terms of diagnostics. So then in terms of education, this was one of our recent papers which we published in Frontiers, which was digital technology for oral healthcare and dental education. So again, we've tried to highlight areas where AI should be more involved, but we've also hinted at caution in some of the areas where we feel human expertise still triumphs any kind of AI interventions. So in terms of evolution, you can see that we've been able to increase our efficiency and accuracy over time. We've been able to reasonably tell patients, okay, you might have a reasonable chance at good progress, you might be able to not be able to be treated with extractions, but again, it's reasonable accuracy. So some of the AI-based applications which are very useful in terms of clinical practice, we have these apps which you can let your patients download. One was developed by the London Dental School, another is a commercial app. So the patient just needs to take their images during treatment, and it should tell the patients if they need to see a dentist, if they have decay, what is the plaque level, which is one of the major problems we encounter when we have long-term patients. So then another area where AI has been very popular is in terms of outcome evaluation. So in terms of patients having satisfaction with the pre and post look of surgery. So for example, you have these AI-based applications where you can upload patients' images and try to show them images of how they would look after surgery. So these are currently at a lower rate of about 66.4 in terms of patient satisfaction. So again, I would recommend using these apps with a bit of caution. Then there are these teleorthodontics applications. So again, I think if you open any banking page, you order any deliveries, you order, even contact the hospital for that matter, most times there's a chance that you're not talking to a human, there's a good chance you're probably talking to an AI-based chatbot. So again, there were two major projects which we worked on. One was again published in the Journal of Orthodontic Science, which talks about the guidelines and teledentistry, how it pertains. We have another upcoming paper in one of the issues of seminars, which is talking about ethics and AI and teledentistry. Then this was one of the funded projects that we ran during the COVID period, where we developed an app for teledentistry diagnostics. So this app is still being used now. It was after the COVID period, we handed this back to the government of Italy. So it was funded by the government. And then we basically used a stepwise triaging process to find out which specialty did the patient need to see for treatment. So let's say they have tooth pain, who do they see? If they need extractions or they have decay, which kind of doctor, and it would automatically set up appointments for them. So now we've downgraded the COVID risk part, but it's been used for other applications. Then in terms of orthodontic research, so I think all of us know about some of these popular apps. So we even asked ChatGPT what are good places to eat right now, what are good places to probably explore in Ho Chi Minh right now. So I'm sure I've seen a couple of friends look up those. So in terms of how we use this for research purposes, I think most of the journals have already implemented guidelines and policies where you have to declare if you've used AI. So I think up to 30% is usually considered acceptable, but other than that, I think it's not acceptable, and it's considered a form of AI-based plagiarism. So again, this has to be taken into account for those who are involved in research. So some of our just latest projects which we've completed, one was dental age estimation. So we took a lot of retrospective records of children, especially a lot of growing children between the ages of 5 to 15. So these were retrospective data for children taken for different purposes. And then we carried out a dental age estimation project based on different factors. And then again, we just completed this project and it was published sometime back in the Imaging Science in Dentistry, which is a very well-known Korean journal. Then our current project, which we are currently working on, which is in terms of, again, predictive classifications. So I think, according to me, like, even though I might not have much of a standing, but the major uses of AI are more in terms of diagnostic analysis, predictive analysis, because we do collect a lot of records being orthodontists. So which is one of the good things, and it's a very important thing in terms of data collection. So this project, I'll show you some of the images, which is, because these days we're using Marpe, we are using a lot of tags in the palatal region. So we thought it would be appropriate to try and classify the palate using AI. So our current results, we are very good with classifying whether there is no tori. We are very good with type 1, but not so good with type 2 and type 3, just because these occur much lesser when we compare it with no tori or probably class 1 tori. So this is the current rating. So you can see some are very good or correctly classified, but very small tori, class 1 or class 2s are a bit difficult or misclassified. So again, similarly for type 1, you can see most of the times it's very good, but there are times when the images are not so clear and it tends to misclassify them. Which again brings me back to my initial point. It's very good to have a lot of data, but it's also good to have a lot of quality data. Because as I mentioned at the start, AI relies a lot on the quantity as well as the quality of data both. So then again, type 2, now we start to go down in terms of accuracy. You can see it's misclassifying very obvious tori as well, or sometimes absent tori, just because of the image being also bright. And then class 3s, it's very low, even with larger ones. If you see there's a bit of gloss in the pictures. So now it's tending to misdiagnose a lot, because we need more quality of data and higher quantity of data as well. So with that, I'd like to just summarize what I managed to cover in this time. So there's a lot of scope in terms of us improving AI models, different iterations of these models, in terms of orthodontic research, education. So in our faculty, currently we're in the process of developing AI-based, case-based learnings for orthodontics. So which is one of the areas where AI is very beneficial to use, and it comes up with a lot of good ideas. And you can actually just use Chat GPT. We are currently using Claude, which is another scientific GPT for AI-based CPL learning. Then we have clinical management of complex cases where it aids you in terms of, let's say, differentiating between surgery, non-surgery, possibly also taking into account the other records so that it gives you a fair bit of an idea of whether this is useful for that patient or not. And then last would be outcome prediction. So this is one area which needs a lot more work compared to the other areas, because to be able to predict outcome correctly, we need a lot more data. So again, quality and quantity of data. So then there is significant potential in terms of diagnostics. We can analyze radiographs and images very well. So wherever you have very clear data, you have numbers, AI tends to be very good at those areas. But because the human mouth is a complex area, we have lots of variations between every two people. So it will be some time before we can with reasonable accuracy decide treatment planning or carry out treatment planning using AI. So I've seen a lot of the aligner companies are using AI, but if you notice, the aligner fits or the movements don't track very well, just because it's more difficult to simulate the periodontal areas, the bone conditions using AI. So it just takes into account standard values and decides to carry out standard treatments. So with that, I'd like to conclude saying that we can use AI a lot for diagnosis, for personalized treatment plans, and eventually our end goal is to always provide better patient outcomes. So that's what we are using AI for, or for that matter, any other modality, because we want to be able to treat our patients more effectively and more efficiently. So with that, again, it's an honor to be here among such well